Documentation drives practice. Good documentation provides a picture of the pain a person has experienced, so it should reflect the person's lived experience. Documentation can also give a voice to the residents who can't or won't communicate about their pain. Documentation allows for good communication between your staff and the multidisciplinary team, as well as during handover. Accurate documentation guides you on what is the best treatment option. We use documentation to measure the person's response to treatment and, in consideration of the person's preferences, change it as necessary. There are many places where pain information may be documented. For example, common documents with pain-relevant information are the medical history on admission, newly diagnosed conditions from GP, specialist letters or hospital discharge summaries, pain history, progress notes, medication charts, routine pain assessments, pain charting such as the 3-day pain chart, behaviour charting, mobility and transfer assessment reports, allied health related notes such as from podiatry or dental services, lifestyle notes or resident participation. Comprehensive medical assessments including the family's report of the resident's pain history and palliative care documentation. There's a lot of documentation, but it's all important to provide best care for our patients. Nurses rely on personal care assistants to report to them directly and accurately, chart pain when it happens, supported by good progress notes. This is how we can all do our bit to recognise and document pain to contribute to best practice pain management. How can we make practical improvements in documenting pain in residential aged care facilities? What does good documentation look like? Here I'll show you some examples. Just writing with good effect in the progress notes does not provide sufficient information. It is better to describe the effect in more detail. For example, you could write that the resident says they are able to enjoy exercise class without pain. Analother example could be resident no longer groans during transfer. Medication charts should be complete. State when the PRN analgesic should be administered. Pain charts should state when an assessment was carried out, not when you intended to carry out the assessment. Be suspicious when the times are always exactly on the hour and follow up with staff to ensure that these chart assessments were carried out in real time. Pain charts should include observation when the resident is moving around and during activities, and not just when they are at rest in bed or a chair.